We are to part 3, the final part of the lecture. This is the smallest of the 3 parts, so if you have any questions or concerns, again, feel free to get back with me, and I'll answer any questions that I can. Thank you. Didn't know why these aren't wanting to open. All right, let's talk about the infectious now. When we get ready to talk about the infectious part, we're going to be talking about meningitis. Let's see, I think it's around page 950 in your book. Yeah, page 950 starts talking about meningitis. Of course, meningitis is an inflammation of the meninges. It can be bacterial or it can be viral, and there's a larger number of bacterial than there are viral cases. It is the most common central nervous system infection. An infection can occur in the cerebral spinal fluid when it becomes filled in the subarachnoid space and becomes infected. It may develop from bacteria that's carried in the bloodstream, or it can go through and enter through a cranial structure such as the nose, the ears, and the sinuses. So it can start out with an infection like that and can become meningitis. Any disturbance in the blood-brain barrier, including a skull fracture, can cause an injury port as well. And after the bacteria enters the subarachnoid space, they can multiply and spread to the ventricles, causing the inflammatory response. The exudate then will spread into the cranium and the nerves and obstruct the flow, resulting in hydrocephalus, the communicating type. Those who are at greatest risk are those less than 1 year of age, infants. Children and the elderly also have a high risk of developing meningitis. But most cases are seen in children, especially those younger than 1. And the highest risk age groups is those less than 1. The 2 main types of causative organs, again, are bacterial and viral. You can look through their bacterial, some of the main causes of Meningococcus, pneumococcus, and influenza. With the virus, also known as aseptic type, if you see aseptic, that means they have viral meningitis. It's a large variety of viral agents, like your Coxsackie virus, your echovirus. A lot of those viruses can be common. Let's talk about bacterial first. The clinical manifestations of bacterial really depends upon the age, the pathogen, and how long before the diagnosis is made. But in general, in infants, you'll see things like fever, a change in their feeding behavior. They won't want to eat. They'll be hard to cuddle and sull. Rocking seems to even make it worse. They have a high-pitched cry. They may have bulging fontanelles and irritability with vomiting and diarrhea. But the bad thing about it is they can't tell you. With the older child, you may see nausea and vomiting as well, febrile, irritability, joint pain, headache. The photophobia may be very comfortable, hard getting into a comfortable position. Positive Kernig and Brzezinski signs. And if you don't remember what those are, you need to look those over again because we've already been over those. But look those over if you don't know. They will be on the test. The 3 classic signs in the older child that you'll see is headache, fever, and stiff neck. Headache, fever, and stiff neck. Those are the 3 main things you're going to see in the older child. Classic signs and symptoms. Headache, fever, and stiff neck, also known as nuchal rigidity. More than 95% of patients presenting with meningitis will have these 3 signs and symptoms. Oops, sorry about that. Diagnostic evaluation for bacterial meningitis. Lumbar puncture is the definite diagnosis of examination, and they're going to be looking at the white blood cell count, which would be increased, an increase in protein, and a decrease in glucose levels. Now, you would expect normal levels with viral and decreased with bacterial. So that is the main way you tell the difference in bacterial and viral meningitis is looking at the glucose level. With both of them, you're going to have an increase in white cells. With both of them, you're going to have an increase in protein. But with bacterial, you'll have a decrease in glucose because the bacteria are using the glucose for energy. But with viral, the glucose level usually will be normal. They're going to identify the causative organisms, whether it's viral, bacterial, fungal, parasitic, and they're going to actually try to take care of that. Now, when you're looking at the culture, usually white blood cell, your norms, so that you'll know the norms for a white blood cell is 0 to 5 millimeters cubed. 0 to 5 millimeters cubed. Anything above that would be increased. Your normal glucose level is 45 to 80 in the cerebral spinal fluid. 45 to 80. So anything above 80 would be increased. Anything below 45 would be decreased. Protein level is normally 15 to 45 milligrams, 15 to 45. So if it's increased protein, anything over 45. Your pressure is usually around 70 to 180. Crying and things like that elevates the pressure, so you have to be very careful and try to keep them calm. Usually the color, again, we talked about cerebral spinal fluid other, is clear, and they may have to use something to calm the child. Now, if I was getting ready to do a culture and I was wanting to know the difference between viral and bacterial, and I was going through there and looking, a lot of people think if you're just looking at the color and if it's cloudy, it's bacterial, and if it's clear, it's viral. That's not the case. There are some cases where clear can actually be bacterial and cloudy can be viral. So for the most part, though, if it comes back cloudy, it is bacterial, clear, viral. But just know that you can't tell by that alone because it can be the other. Opening pressure is going to be high on both of those, so it'll be above 180. If we're looking at the white blood count, with the viral, the lymphocytes would be the dominant one, the lymphocytes. With the bacterial, the neutrophils would be dominant, the neutrophils. And y'all learned that a long time ago. Neutrophils up, bacterial, lymphocytes up, viral. Proteins up in both of them, greater than the 45, so, and usually you can even see it in the 70s. Now, with the viral, looking at the glucose, it's usually normal, so you would expect it to be between 45 and 80, but it's going to be decreased with bacterial below 45 because, again, the bacteria is using that as part of its energy. So you do need to know those labs, and you do need to know the difference in viral and bacterial. Okay. Initial therapeutic management involves isolation. This may be initiated until the organism has been identified. So in other words, we're going to go ahead and put them in isolation, and even if we don't know what it is, and assume it's bacterial just in case. Because meningococcal meningitis is the only form that's readily transmitted to others, an epidemic form. So in case they have that type, we do put them in isolation. Respiratory isolation is also instituted for at least 24 hours after antibiotics are started. Once they have been on it over 24 hours, then they are considered non-infectious, but they have to be on the antibiotics for a full 24 hours. Now, this rash, the meningococcal meningitis, a lot of times has a rash. It's a purplish rash, petechiae ecmosis-like rash. Kind of looks almost starts to look like a rug burn, and then it rapidly spreads to a petechiae rash. If you let that go, sometimes that is a sign of impending vascular collapse, and you do have to make sure that you have them in isolation, giving them antibiotics. As far as antibiotic therapy, the IV is started as soon as the lumbar puncture is complete, and they're going to be getting large doses. The choice of antibiotics is based upon the sensitivity. If they don't know that, they'll give them some gram that fights against gram positive and gram negative. So they're going to be doing a culture and sensitivity. They'll be given things like gentamicin, ampicillin, things like that. Adequate hydration is important. Correct them with fluid deficits. Ventilation may be necessary if it gets too bad. Reduction of increasing of cranial pressure, and management of shock and signs of shock if they start having that. Also, seizure control is important. So you may, if they're starting to have seizures, you'll have to give them anticonvulsants. Temperature control, correction of anemia if they develop anemia, and watching for complications like subdural effusion, DIC, and shock. Remember, they most of the time have photophobia, so you want to decrease stimuli, make sure the lights are dim, and that you're letting them get in the position of comfort. Nursing considerations, you need to know these. The first priority is isolation. You want to make sure they're in isolation and that you get their vital signs and start administering the IV antibiotics. So isolation precautions, getting the vital signs, and getting the IV antibiotics started as soon as possible. A lot of times after they do the lumbar puncture and ER, they'll go ahead and start their antibiotics downstairs so that is already underway before you get them. Generally, no more than 15 minutes from the time of arrival, you should be getting all this and getting it set up. IM antibiotics are not acceptable because the serum levels would be too low. It has to be IV for at least 10 to 21 days. Restraining devices will be required to make sure that they don't lose the infusion devices as well. During this time, you want to promote comfort, keeping a calm, quiet, dark environment. Remember, they're photosensitive. Side lying position is most comfortable without a pillow, head of bed elevated. That helps with that nuchal rigidity, the stiffness in the back of the neck. You want to promote comfort. They're often restless and prone to seizures. Monitoring their vital signs during neurovascular checks, level of consciousness, or neurological checks. I&O. Signs and symptoms, watching for increase intracranial pressure, and providing lots of support to the family. This will usually subside on its own after several days of IV therapy. Non-bacterial or aseptic meningitis type is a benign syndrome. It's caused by a virus associated with other diseases as well. Initial symptoms are headache, fever, malaise, nausea, vomiting, and signs of meningeal irritation. So if you look, it has a lot of the very same signs and symptoms of bacterial. That's why we can't tell a lot based upon signs and symptoms, so we put them in isolation just in case. They'll still have the irritability, the stiff neck, the back pain, and the positive Brzezinski's and Kernig sign. Less common symptoms would be a sore throat, generalized muscle aches and pains, a maculopapular rash. Diagnostic is based same as the bacterial meningitis. You have to differentiate the causative organism, whether it's viral or bacterial. And remember, if you're looking at the cerebral spinal fluid, the cerebral spinal fluid glucose will remain normal. Treatment, the child's treated as if they have bacterial until the diagnosis is confirmed. So it's going to be symptomatic. Antimicrobial agents will be administered as soon as they figure out if it's not if they figure out it's viral, they will discontinue that. So care is very similar to that with bacterial. Encephalitis, also known as sleeping sickness, is an inflammation of the brain tissue with its covering. It occasionally involves meninges of the spinal cord. It is caused by a variety of organisms, but viruses are the most common. It affects about 1 in 12,000 children each year, so not very common. Can occur by direct invasion of the central nervous system by a virus, or the most common way is post-infection involvement of the central nervous system after a viral disease, particularly those involving arthropod vectors like mosquitoes. So you want to question them about recent immunization, insect bites, travel. Of course, you would see this more in the hot summer months. Clinical manifestations of encephalitis is in your book, I believe, on page 954. On page 954, if you look there at the signs and symptoms, you'll see things like, and there's a good chart also on 954 telling you the difference between viral and bacterial meningitis. Clinical manifestations of encephalitis: malaise, fever, headache, dizziness, apathy, lethargy, nuchal rigidity. What's that sound like? Meningitis. So this gets confused a lot with meningitis. And it takes a little bit before sometimes they diagnose it. They're not getting better, so they'll go ahead and do a biopsy and they'll figure out that they've got encephalitis. They'll need to be put on seizure precautions. Diagnosis is based upon clinical findings and circumstances associated with the disease and identifying the virus in the blood in the cerebral spinal fluid. Treatment is supportive, control the neurological symptoms, adequate nutrition, and hydration. So nursing considerations are similar to the care of the child with meningitis. You're going to be monitoring them and their cardiorespiratory function, reorienting them, doing a lot of teaching. And some children don't make it with encephalitis because they don't get diagnosed in enough time. Reye syndrome, and we already went over. We'll just hit some high points of it again, also known as toxic encephalopathy, or RS. It is an acute metabolic encephalopathy of childhood that affects the liver, causing hepatic dysfunction characterized by cerebral edema. So you got an enlarged fatty functioning liver and cerebral edema. So you're talking about the brain and the liver being most affected. Etiology is unknown. Most cases follow a common viral illness, most often influenza or varicella. There has been studies that show an association between aspirin administration and following these viruses and Reye syndrome developing. Diagnosis is based upon abrupt signs and changes in the child's level of consciousness and increased liver enzymes and ammonia levels because the liver's not acting correctly and absorbing that, and fever. There is staging criteria of Reye syndrome. I think 956 maybe in your book is Reye syndrome, yes. It talks just a little bit, not much. But if a child's in 0 to 2 stage, then they're pre-comatose. They're going to have a lot of lethargy, delirium, some combativeness. But as they start getting into stages 3 through 5, they start going into a coma and progressively getting worse, with heart and lung functioning decreasing. Definite diagnosis is made by a liver biopsy. So again, if they're in doubt, they will go ahead and do one, or even if they suspect a child has Reye syndrome. In most cases, children seem to be recovering from a viral illness, and then all of a sudden they'll have nausea, vomiting, fever, lethargy, stupor, coma, convulsions, combativeness. That's a red flag right there. That's your red flag for Reye syndrome. Death can occur within 1 to 2 days of the onset, with 30% of these children dying despite treatment. Therapeutic management, the most important predictor of successful management is early diagnosis and aggressive therapy. They're going to be in ICU because they can deteriorate so quickly, and they'll need a lot of monitoring, such as intracranial pressure monitoring. They may need tracheal intubation, skeletal muscle relaxants. So they have to be watched very carefully. They are very sick. So you're going to do careful monitoring of vital signs, assisting with the lumbar puncture, IV lines, monitoring their increased intracranial pressure, and the key is to try to catch them when they're in stage 0 to 2 and keep them from going into stages 3 through 5. If you can do that, then the possibility of them surviving is much better. You want to observe them for impaired coagulation. That's very important to remember, impaired coagulation, such as prolonged bleeding. Remember, they have liver dysfunction. So think of nursing interventions that you would not want to do then. Rectal temps, IM injection, anything that would potentially cause a bleeding problem. Teaching regarding the sources of aspirin or salicylate, such as an aspirin Pepto-Bismol, and it actually is a derivative in ibuprofen. Provide the parent and the family with support during this time because they are going to need it. There are 40 questions from my section. I wish you only the best on the exam. I know you can do this. Think positive. I've enjoyed teaching you this year. Best of wishes to all of you and all your future endeavors. And if I can ever do anything for you in the future, let me know. Thank you.